The discussion about comorbidities also, these folks are starting with their MDS at a median age of 70, 71 years. So there's a big discussion about competing risks in MDS. A person's risk of dying is not just because of the MDS. It's also, at least in Ohio, because of things like heart disease and high blood pressure and diabetes and a host of other things that people have.
Well, also the interesting, fact that many of these mutations that we talk about in MDS have a correlation with cardiac risk. And we're sort of at the beginning of understanding what the relationship might be of a person who has CHIP, for example, and has a DMT3A, what their cardiac risk is. So, these patients probably have cardiac risk, all up front, with the availability of these mutations, but we haven't fully investigated what those are. The 71-year-old patient, you have a whole gamut. 71 is a number, but in the older age group, number may not be so important. You have a 71-year-old who's running 5 miles a day. That patient, if you look at the recent New York Times article about aging and muscles, that person may have 25-year muscles, but, is 71 years old. But you also have a 71-year-old who has been smoking for 40 years and, maybe on intermittent oxygen, who is also 71, or a diabetic who has, had many complications of their diabetes, who's 71. That patient is a much older 71 than a 71 who is physically active. So number isn't everything. You really have to look at how fit that patient is in their overall ability to perform their life's activities.
I feel like I'm the opposite. I have 71-year-old muscles most days.
Yeah, we have to do some work on that as hematologists, right?
And does that influence your treatment decisions about patients? Let's put transplant aside, because transplant, you have a comorbidity index score that you can calculate based on comorbidities and likely outcome with transplant. But in your day-to-day decisions about treating patients with common drugs for MDS, do comorbidities influence that, or do you just go ahead and treat away?
I think it's hard to distinguish some of the performance status deterioration that may be arising from the disease itself. If you have someone who's anemic, hemoglobin of 7 requiring transfusion, well, maybe treating the disease will improve that. But it's different if you have someone who may have CKD, kidney, rising creatinine, which may influence the dose that you're about to give. That's a different story, and I think that distinction needs to be made.
Yeah, I think you nailed it. Like, there are patients that you will start the treatment actually because of the comorbidities. If somebody is having unstable angina when they are anemic, usually we may wait till somebody is below hemoglobin 8 or 7 to treat. But if somebody is having, comorbidity that improving their anemia will make it better, you may actually treat earlier. And then sometimes the choice of treatment, the dosing is adjusted based on the comorbidities.
But the other factor here is, for me, when we start a patient on an HMA, we're asking these patients to come monthly, to the clinic to receive 7 days of azacitidine, and it is a commitment that patient makes long term to a treatment. So I also look very carefully at what the caregiver status is for that particular patient and what their ability is to actually make that commitment to come every single month, in the first couple of months to be able to come in, regularly, potentially to need transfusions until the therapy starts to work. So it's really complicated when you're actually figuring out the treatment plan. A 90-year-old woman, who's kind of fit, who has a 95-year-old husband who's taking care of her and is driving her back and forth to the clinic to be able to get these therapies. You really have to think about how feasible that is and have a real discussion with your patient as to what the commitment will require. I find that more and more an important aspect. Who's going to take care of them? Who is around for that patient? Are they able to make the commitment to come in as frequently as they need to? If they have a fever, come in, for IV antibiotics. You really have to know that information up front. You have to really know your patient before you make the commitment to treatment.
I think that was beautifully stated. It's because these are long-term commitments. These are therapies that require people to come into a treatment center frequently. And these are older individuals who have spouses who are older individuals as well and may have other medical conditions that they're trying to manage at the same time.